I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Fridays with Faisel. We're here because everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is hospital error, medical error and hospital terror. The reason for this topic is many people don't realize that hospitals aren't as safe of a place as many believe them to be. Actually, 1 in 200 people who get admitted to a hospital anywhere in the United States will die. The risk of dying from jumping out of an airplane with skydiving is 1 in 2,000. Literally, it's 10 times safer to jump out of a plane than it is to be admitted in a hospital in the United States. I'm excited about this week. Robert, you ready to get this show? How's it going? Good to see you.
Hey, yeah, so I have a new webcam, so I'm in HD, so we're gonna deal with the consequences of that.
We're getting fancier by the week. By the way, how awesome was the video promotion?
Oh, that was hilarious. I mean, well, this is a very serious topic, and we're obviously very passionate about, keeping people healthier, preventing medical error and keeping people out of the hospital. We did think that it was a good topic for the week of Halloween.
Yes. Let's just introduce our guests. I'm excited to have both of our guests come back. We have Dr. Gheewala coming back on again. And then please, if you can introduce Jerry. Yes. Dr. Gheewala can give some of our ways of preventing people from going to the hospital unnecessarily. But I'm very excited about the guest that you invited to talk about some of the neat things that he's doing from the technological point of view with the gadgets.
Yeah, glad to have both of you here, Dr. Gheewala and Dr. Wilmink. So Jerry Wilmink is Chief Business Officer of CarePredict. They are and I'll let Jerry introduce this better than I can, but they use technology and wearables to actually try and predict when somebody's at risk for certain health events in order to try and keep them out of the hospital. So we're going to talk about a lot of great prevention techniques to keep patients sort of in a primary care setting or in their homes away from the healthcare facilities, so as to prevent potential medical error and to just keep people healthier ahead of time. So prevention is sort of one of the core themes of today's chat. And just to set the stage, I want to bring up a quick graphic to discuss something that I don't think is widely known. So can we pull up that graphic? So this is from the British Medical Journal. It's a study of CDC data looking at cause of death in the United States. And as you can see, if medical error were actually tracked on death certificates, it would actually be the third largest cause of death by this estimate. And so it's something that we want to talk about in the context of, well, we want to prevent heart diseases and cancers and sort of those sort of mainstream major causes of death in the United States by, improving primary care and keeping people healthier so that we're preventing a hospital stay. But at the same time, we want to prevent hospital stays because it's a complex environment where sometimes medical error can lead to death as well. So the goal here is generally keeping people healthier, keeping them out of the hospital. So that's kind of the topic today. And we think it's a pretty interesting thing to talk about. And it often misses the sort of mainstream conversation. So I'll turn it back over to Dr. Faisel Syed. Well, actually, why don't we let our guests introduce themselves as well first? So Dr. Gheewala, why don't you go first? And then Jerry, why don't you go next?
Absolutely. It's great to be back. I'm Nehal Gheewala. I'm the medical director of a ChenMed location here. It's a dedicated senior medical center in Tampa, Florida. I'm very excited to be here today to talk about medical error with you guys.
He's also my dad's primary care doctor.
Thank you.
Full disclosure.
All right, and Jerry. Tell us what you do, where you come from, what you're interested in. I know your story particularly well because you actually are featured in a chapter in my book. So I think I have decent knowledge of how you got to where you are and what you guys do. But yeah, definitely give us the synopsis.
I will. Thank you again for this opportunity. So my name is Jerry Wilmink. I'm the Chief Business Officer at CarePredict, and we're located down here in Plantation, Fort Lauderdale, Florida. And we also have a location out in Menlo Park, California, where our CTO and our data science team works. What we've developed is a digital health platform that actually measures changes in a senior's activity and behavior. So changes in their eating durations, their physical activity levels, even the time that they spend outdoors or socializing, and uses that to predict when they're at risk for depression, a urinary tract infection, or even falls. We have several peer-reviewed publications that we recently have published. And I've been in the senior care space from the technology side for well, I guess since I finished my PhD. I did my PhD at Vanderbilt University in biomedical optics, optical sensing. And after that, ran a sensing laboratory for the Department of Defense and started my first company called Wiseware after my grandfather, Dominic Camerata, was suffering from Lewy body dementia. He fell in his home and passed away, and I started a company developing wearables and actually biosensing hearing aids to predict when a senior was at risk for a fall, because prediction is much more important than reacting quicker. So very honored to be on the show and happy. Robert and I have had lots of meetings and discussions, and I'm a big fan of all of your work, and Robert, your book as well. So I'm excited to be here.
Thank you so much, Jerry. Thank you for joining us. I'm so touched by your story, especially with your grandfather, and how that inspired you to help predict someone's gait. Letting people know. Many people don't know when the gait changes. We hear it all the time in the centers with the elderly, and then to have a device that could predict that or let them know, alert them that, hey, your gait's getting a little bit off here. Exactly. I'm excited to hear about some of the other ways that you can use that technology with COVID, with contact tracing and all that stuff. I mean, that sounds really neat. Mm-hmm. We have to, Dr. Dan. Where's Dr. Dan? We got to get Dr. Dan. Dr. Dan.
Hey,
moderating.
How are you?
I'm doing really well. Dr. Dan's going to be moderating the chat. We really encourage people to chat on all the platforms. Dr. Dan will be manning the chat and then also bringing in some comments that we could bring into the discussion so that we could all talk about it. We really want this to be as interactive as possible, especially these days when we're all forced to be living in this virtual sort of space. Let's try to make the best out of it.
Absolutely. Please chat your questions and we'll get to them as quickly as we can.
Thank you, Dr. Dan.
So Faisel, I think a great way to start this conversation off is sort of going into the clinic. And you and Dr. Gheewala can talk a little bit about how at ChenMed you have experienced medical error among your population, how you try to prevent it, and just kind of introduce the topic from a primary care perspective.
Sure, let's get started. So pre-COVID, important thing to remember, pre-COVID, half of all medical care in America was delivered in the emergency room setting, okay? Many people don't know that the medical records in the hospitals and the emergency rooms oftentimes don't talk or communicate with the medical records for patients and with their primary care doctors and their outpatient specialists. So simple, just very, very simple things like medication error, allergies aren't relayed back and forth. And when you're dealing with our patient population, our average patient is 72, 74 years old. If they're going to the hospital, oftentimes they may not be able to recall in that moment's notice what medications they're allergic to, what their medication list even is when they're in an emergency situation. And many times emergency rooms offer these bundled sort of treatment algorithms or response algorithms. They'll have a CHF protocol, congestive heart failure protocol, or a COPD protocol or chest pain protocol. And that's where many mistakes happen right in the beginning in the emergency room setting. because most of the doctors and the staff in the emergency room, they don't know the patients like the primary care doctor.
I agree with you 100%. I mean, this is what we see. We take care of the old, the sick, the poor. And we see that they have, when they come to us, they have very fragmented care, which is just introduces so many poor opportunities. I call them poor opportunities because it's not a good opportunity to have an error. To have an error, we get these patients and they come to us and they've been to so many places. And, you know, looking at just what is medical error, like just starting from just what the definition is, it is preventable, adverse effect of care, whether or not it's evident or harmful to the patient. That is medical error. And we see that sometimes error can just happen without any actual effect to the patient. Thank God. But that is very much part of the problem. And we see that quite often here. We have a lot of patients that come in with old medication bottles. I had one this morning that came with multiple old medication bottles. He was sitting there at home trying to dose himself. He was cutting some pills in half some day, taking a whole pill another day. And it really kind of boiled down to communication, right? It's a polypharmacy. And then we can get into the causes and to the solutions, but there are many causes of medical errors. I mean, including not just medications, but you think about if they get admitted to a hospital, especially for something unnecessary. Now, people, if they have to go to a hospital for they have a stroke, they have a heart attack, God forbid, of course. But even while they're there, sometimes too much is not good for the patient, right? You know, less is more. That saying is very much applicable here. Anesthesia has caused medical errors. Hospital infections, my God, how many times have we had a patient that has gone to the hospital and picked up pneumonia? Or how about COVID? How about the flu? Missed or delayed diagnosis, and even inadequate follow-up. Like Faisel was saying, communication is key. And many times we find that when a patient goes to the hospital, there's actually a broken line of communication between the hospital and back with us on the outpatient side. It's not that they don't know who we are. No one's just picking up the phone and calling. And it leads to a lot of medication errors, a lot of misdiagnosis. The patients may not be able to remember. They might misrepresent themselves because they are unable to. But, you know, for an ER doctor or for a hospitalist who's never seen this patient before, or an intensivist, they're doing what they think is right. And if somebody had, picked up the phone and called, the primary care doctor can provide the last echocardiogram. They can provide the last labs, the notes. They can provide context. They can provide family context. They can give you the DPOA. Think about how many errors and how long, the length of stays that we have because of DPOA. So this is just a very intertwined subject, right, Faisel?
Mm-hmm. Oh, I mean, and you're making me think about just inefficient care in general. You know, when you have half of all medical care being delivered in the emergency room setting, it is not the most ideal care. How many patients we've met in our centers who they went to the emergency room because they were not feeling well. Turns out their blood sugar was through the roof. And what do they get started on? Insulin. And then they'll come to and then for decades, they're seeing primary care doctors or nurse practitioners or whoever in the primary care system who are refilling insulin rather than having conversations about lifestyle or even just taking oral meds before going to the insulin. They were starting the insulin in the emergency room, and then they get continued on insulin, and then we'll see them. So then we'll see them, after they turn 65, they're in their 70s, and then we'll take a look at them, and we'll start having conversations. I can't tell you how many diabetics who I met on insulin, we've gotten them off of insulin within a few months of just meeting us, just by giving them some basic coaching, basic lifestyle recommendations to reduce, the basic education, reducing carbs, talking about, what they could do so far as physical activity is concerned. And they thought that they'd be on insulin for the rest of their lives. And then they think we're God's gift to medicine because we're getting them off of insulin.
Right. So, what I'm hearing from both of you guys is obviously the emergency room setting is not designed to take care of patients with chronic illness. It really is designed for emergencies, for really acute episodes where they can stabilize a patient and either admit them to the hospital for longer term care because they're unstable or send them home. But that sending home is not necessarily communicated, and it's not a part of a larger treatment plan that's really essential from a primary care physician that has sort of long-term sort of care responsibility for that patient. And so when we're trying to prevent hospitalizations in the first place, that kind of starts at preventing those emergency department visits. And it also starts with keeping the patient healthy by addressing a lot of those factors of chronic illness, like the ones that develop like heart disease and like diabetes. And so those lifestyle factors, those socioeconomic factors that impact health, primary care doctors have a little bit more ability to spend time and to address those issues over time with that patient to prevent those sort of bad, mismanaged conditions from ending up actually in the emergency department. But at the same time, when you get to the emergency department, it's not just about keeping patients healthy, it's preventing those because bad things can happen when the patient is in the hospital. So prevention here is the core centerpiece of actually what we're talking about today, from both typical chronic illnesses and from medical error. So I think that's a really great way to jump into a lot of what Jerry does. Now, both of your companies work with the same patient population, the older adult population, people who are on fixed incomes. And the goal is to prevent them from ending up in the hospital because they're the ones most likely to do that. So Jerry, we'd love to hear a little bit from you about your view of prevention and how you've used technology to actually prevent some of these really frequent events that lead people to the hospital from occurring.
Yeah. Well, thank you again. The thing, as you were speaking, I was thinking about my grandfather. When I was younger, we lived in one house. It was me, my mother, and my grandparents. And we lived under one roof for our own financial reasons. And we were there though. See, the advantages of this is I could see with my own eyes when my grandfather, when he had changes in his gait, I could see if he was skipping meals, if he was not participating in watching his normal TV shows or things that he normally would engage with. We would see those things. But now, fast forward to where we are today, we're all physically and geographically separated. So we don't have those eyes and ears to see those changes in activities and behaviors, which we know precede a health decline. What we've done at CarePredict is developed a very unique wearable device. And this wearable has a ton of different sensors that autonomously measures changes in kinematics of the senior's wrist. And as they bring, for instance, food from table to mouth in the dining room, it knows that they're eating or drinking. Wow. If they're in the restroom, washing their face.
Love it.
And autonomously measuring that, right? So now this is our eyes and ears. And the way we really get this done is we have beacons that are installed throughout the home to give us the location and the context. Without that, the gesture recognition, say with an Apple Watch or a traditional wearable, they don't know what room they're in. And brushing teeth looks very similar to eating. So we've used that as really the engine and been able to predict a senior that is risk for a urinary tract infection days in advance. And so that we can get them antibiotics instead of ending up in the hospital, where then that could lead to a staph infection or worse. Falls, we've reduced falls in our communities over a 24-month period by 69%.
Wow.
And this is tremendous numbers where lives are actually being saved, because my grandfather, after he fell in his own home, it was only a few months later that he passed away. So predicting and preventing falls and urinary tract infections and even depression. One thing I forgot to mention is this wearable is actually housing a whole myriad of different types of sensors. So UV light, infrared light, pulse oximeter for blood oxygenation levels, heart rate, temperature, humidity. All that sensor fusion goes on right here at the edge, and then the predictions are sent to either the home care staff or, in the senior living environment, the care staff that are there in the independent living community.
Wow, that's brilliant. That's Jerry, many people don't realize that with the elderly, the mortality with a hip fracture, like with elderly people having a hip fracture, the mortality is some ridiculous number, right, Dr. Dan? And like over 50% of people will not live like 12 months or something like that, or half.
Over the age of 60, the 1-year mortality rate is somewhere between 25 and 50%.
Wow.
But it goes up about 4% per year. So when you think about what's happening when you get into your 80-year-olds, the risk of a hip fracture. So preventing a fall is, that's as good as bypass surgery in the right patient. I mean,
That's right.
but Jerry probably gets paid a lot less for it. Yeah, so we've got,
No, go ahead.
we've got it. I was going to say we had a couple of questions that I would get in if we have time to do that.
Let's do the pharmacist one. I love the pharmacist one.
Okay.
Yeah.
So Hector asked, what is ChenMed doing to establish meaningful collaboration with pharmacists to prevent medication-related preventable adverse events?
Oh, this is fantastic. This is an excellent question. So we have a great team of pharmacists. They do med rec reviews. They look and see if medications are up to date or old. They make phone calls to patients. When it comes to any of the HEDIS medications, especially those, any HEDIS measure, our pharmacy team is on it, making sure that patients get those medications to them. We actually do have our own pharmacies as well, built into our centers, so that if a patient comes into our center, our pharmacy team at Central or any of our pharmacy technicians they get an alert if a patient's due for a medication, and we can just go ahead and refill it for them, or we can send it to their pharmacy of choice. We actually also, not just pharmacists, but we have community case managers that go to people's homes. And that is actually where you will learn the entire story. Very much like what Jerry's saying about having beacons set up across the house when nobody's home. A thing that we use is our acute community case managers. They will go out to somebody's home. And it's not 24-hour monitoring like the beacons, but it is something that we can do to provide. We have somebody go through their medications, especially for our seniors that are bound at home. So, and that information gets translated back to the physicians and the pharmacists. So the pharmacists are extremely key. The pharmacists also look at cost of medication, that is something that's nifty. I mean, we look at, when a pharmacist looks at something, they don't look at just, oh, does the patient need this? Is this the cheapest? Is this the generic? Is this the something that can keep them away from the donut hole? The pharmacist has a incredible vision. It's not just about having breadth of knowledge, they have complete depth of their knowledge as well. So they have been extremely essential to what we do here to take care of our patients. And one thing I also wanted to tie into this, which is the Swiss cheese model. How could we have not mentioned this? I mean, this is medical error is all part of the Swiss cheese model. The Swiss cheese model is meaning that you have an adverse event, and just like Swiss cheese, there are many holes through it. You have an arrow going through it, which leads to an error. And like Faisel, you were talking earlier about insulin. I had a patient that my patient here, and he was with another primary care doctor, was hospitalized due to an adverse event, and he was hypoglycemia. And then he came to me. And he was staring off into the corner of the room. He didn't speak English, so we were using a translation service, and he was talking and he was staring off. After a couple of minutes, I realized he was blind. I looked through his medications. Guess what he was taking? He was using insulin pens. Somebody, not just somebody, multiple people okayed him to be on insulin pens. He's blind. He's blind. And I asked him, how are you doing this? And he, with the translation service, we put the pen in his hands, and he says, I listen for the clicks. That's it. He just keep clicking. So he said, if I'm supposed to go to 3 clicks, I do 3 clicks, but he never knew what number he was starting off at. His A1C was about 14 because he had highs and lows, and he was getting hospitalized. We brought him here twice a day for 2 weeks. I did his glucose logs for him. We brought him to and from the center. We provide transportation for him, did his glucose logs. Turns out he only needed metformin and glipizide. And the glipizide was only temporary. He was eating something in his culture. It was called malanga, very high in carbohydrates. We took that away from him, and he ended up being just on metformin with an A1C of about a little over 7 with diet control, and we used pill pack. We used a pharmacy nearby who was packing his medications into blister packs, and he would take them, and that was the end of insulin for him. And then that was the end of hospitalizations. But he fell into the Swiss cheese model. He had seen outpatient doctors. He had an endocrinologist as an outpatient. My God, I mean, think about that, giving a blind man an insulin pen, then going to the hospital, an ER doctor saw his medications and reconciled them. Pharmacists did it, hospitalists did it, and then an endocrinologist inpatient did it. And this would happen cyclically because no one would step back and look and say, hey, He's blind.
Yeah,
Oh,
that's a phenomenal story. And I think that's incredible. And I have 2 points I think that keep us kind of really at the core of what we're talking about here. The first is pharmacists have been really underutilized in healthcare for a really long time, and their role is becoming more and more important because the acceleration of drug discovery and the sort of large amount of drugs that have come on the market in the past 15 years has really overwhelmed a lot of physicians who have to keep a lot of things in their head already. And so having pharmacists specialize around medication therapy has really allowed them to kind of come to the forefront to be partners in care for patients, because their body of knowledge specifically around drugs and cost of drugs and medication therapy management has been essential. They've previously sort of been pushed behind the counter at a CVS or a Walgreens, and now they're sort of starting to come into more clinical services. And I think that's really, really important for a lot of the issues we see with medication adherence and medication list errors and polypharmacy patients. So I think that's really great that you guys are incorporating that into your clinical model. But what I'm hearing here from all of you that I think is really, really important is the importance of data transparency and data sharing across healthcare providers, and the sort of communication among healthcare providers and to the patient. And I think that, Jerry, your technology really allows for the collection of data in a really scalable way to, be able to make that available to family members, to patients, and to care providers when necessary. So now that patient data is all available and it's very actionable to try and work towards prevention. But the sort of health services world has not done a very good job with that. So like Faisel was saying at the beginning, the emergency department doesn't see the same information as the primary care provider. They don't call each other. So there's not a lot of people who are working to kind of cohesively provide care for patients. And so that's something that I think has been a big goal of a lot of organizations, is to get that, data transparency, those medical records available to all the people who touch the patient. And so that's been a huge limitation in healthcare, and that contributes to that Swiss cheese model quite a bit, because there's just so much these data silos and these communication silos that touch the patient. So I think that's something that, when we think about prevention, can really continue to improve the way that patients receive care now that we have all this technology available and these records that are digitized. So I just want to make that point. I think it really underlies everything we talk about here.
And so I will just make a comment about that, and then we have another question. And the comment I would say is the incentives right now pay people for all those inefficiencies. So when somebody comes to see the primary care doctor and the primary care doctor can't get their records, they repeat the test. And so that can be solved, but you have to solve the incentive portion and quit paying people to do redundant work. So we had Saqib, and I may be pronouncing his name wrong, ask a question as how COVID affected the patients who feared to come into healthcare clinics. And I mean, I think, and I don't know that you would call it medical error. I mean, how COVID has affected patients in general. I know of at least one case in one of our markets where we had a patient going to the hospital for an elective procedure. I think the PCP had even cautioned this patient against going to the hospital during COVID for the elective procedure, but the patient caught COVID while they were in the hospital and then later went on to die from COVID. So they were actually relatively healthy. I don't know, do we call that medical error or not? I mean, she had informed consent. She decided to go have the procedure. But this brings up a good point about how have we approached the patients who didn't want to come in due to COVID.
It's system error. It's a fee-for-service system error. When the incentive in the system is to generate revenue by billing, it is a system error that encourages. I mean, with our current system, 95% of healthcare is fee-for-service. It's a transactional model. And when we're saying that half of all medical care, at least prior to COVID, was being delivered in the emergency room setting, it's at the ER rates. My pneumonia, when I had pneumonia, it was 2 years ago, that would cost less, the same treatment that they offered in the emergency room to me, would cost less than $10 in the outpatient setting. They billed the insurance company $10,000. So when we're saying that half of all medical care is given in the emergency room setting, it comes with that cost as well. It comes from, this is a result of this reactive model with people being overprescribed. Even our prescribing styles, our treatment styles we've evolved with the way we approach medicine because of this fee-for-service system. Could you imagine where we have a system where the incentive was to produce more healthy days, where the incentive was focused on prevention, where the incentive was to focus on early interventions like what Jerry is talking about? Well, we see in our world, Jerry, our patients see their doctors on a monthly basis. Every single patient sees their doctor on a monthly basis because our patients have on average anywhere between 5 to 7 chronic medical conditions. You can imagine, you're dealing with 72-year-olds. They're all on fixed incomes. We're in the most underserved neighborhoods across the country. So we exist in the neighborhoods typically where there are federally qualified health centers or the public health department. Those are the neighborhoods we exist in. So when we're talking about the type of care we deliver, we go into the areas of most need. And we're incentivized to have more healthy days. So could you imagine if we had a system where that would apply to everyone? Imagine what we could do with the technology that you're talking about here. When I'm reading about states telling patients to start doing contact tracing, hey, you do the contact tracing on your own. When we're all walking around with these things, come on. I mean, this is absolutely ridiculous. I'd like to hear, Jerry, from you about that technology. Have you used it with COVID and with something along those lines?
Yeah.
And could you use it?
Yeah. So we launched with our product, in the context of a senior living communities, we have the beacons in place and wearables, which all staff, residents, and visitors wear. So we know in real time where everybody is 24/7. So when the first cases started to get recognized up in Washington, it seems like months, I guess it's now months ago in February, March timeline, we knew the seniors were the most vulnerable, and in particular in senior living communities, where they're receiving frequent intimate care with their ADLs, their activities of daily living. We knew that was going to be a very high transmission risk, and that those seniors that have several chronic diseases are going to be at very high risk for potentially even fatality. So what we did is we layered in a brand new software offering using our real-time location called Pinpoint. And this is a digital contact tracing system. And all of our customers across the United States and Japan, we made it free. So basically, if you get a diagnosis that someone's infected, a resident, a staff member, or a visitor, that they have tested positive for SARS-CoV-2, you go into our software Pinpoint, and you can go back in time for 2 weeks and get a layout of all the individuals that came in contact with them and the duration, the room that they potentially contaminated, and even if it wasn't through fomite transmission, there could be aerosol that now somebody came into that room afterward and got infected. So we have all of that information. We published this as well in a special issue in JMIR Public Health. And when we announced this, lots of press came out. It was pretty exciting. It was before big tech came into the picture to say, we're going to do contact tracing. So with the smartphone, the smartphone can be used pretty effectively for random incidental contact tracing, so out at the park or, at a grocery store, as long as your smartphone is on you. In a senior living environment, one, most of the seniors actually don't have a smartphone. And two, most of the Bluetooth technologies readily go through nonpolar dielectrics and drywall and ceilings. So and go through walls and windows. So it may look like we are in direct contact with each other, but we could be separated by a pane of glass. And so we're actually not at risk for infecting each other. So there's little errors there for false positives. So with our system, we know exactly that you were in that particular room for that exact duration with that particular PUI.
Yeah, and Jerry, I had the pleasure of seeing this back in April when he was first rolling this out, and it was incredible to see. They have the whole map of the assisted living facility. They have all the residents and the staff with the beacons on, and so they could track the movement for over time to see where somebody actually did come in contact, and it was incredible to see the technology. And it's extremely important that you were able to roll this out, Jerry, because those assisted living facilities, those skilled nursing facilities, they still are sort of those core areas of spread and of death from COVID, because you have an older adult frail population who's most at risk for death, and then you also have everybody sort of in a contained space that really cannot actually self and sort of socially distant effectively. So I think it's a wonderful technology that you rolled out, and a way to adapt what you've been using for preventing falls and for preventing and identifying depression and for urinary tract infections, but now for COVID-19 to prevent the additional infections, or to actually segment people away from those areas of risk.
Yeah, it stopped. I mean, really has been effective because it helps us stop that chain of transmission. And when you're dealing with, many of our assisted living communities, they have memory care aspect where they may not remember who they came in contact with. So our dashboard is incredibly valuable because it's very accurate information that can be passed on to the public health agencies as well, so they can do other types of tracing. But this is highly effective, and the speed and efficiency allows us to reduce the number of cases and transmission by over 55% up to 85%. So in a senior living community where the case fatality rate of SARS-CoV-2 could be upwards of 20%, you could save 5, 10, 20 lives if there's a massive outbreak. And not to mention, all of those individuals are likely hospitalized. So you're really, it's been really rewarding to be able to, at the forefront, to kind of help these seniors who are most vulnerable.
And Jerry, one of the things I thought of after I saw this was, what if this worked in a hospital to prevent hospital-acquired infections, knowing who came into contact with a patient, knowing who walked into the room for staph infections and MRSA and all that fun stuff. I shouldn't say fun, it's actually horrible. But all of those hospital-acquired infections that actually do lead to a lot of these sort of medical error, bad outcomes, and sort of the cost of receiving healthcare services, the unintended cost in lives of receiving healthcare services. How do you guys ever see any sort of hack issues with ChenMed, Dr. Gheewala?
Well, I mean, that's a really good question. I have not. How about Faisel?
Ask the question again. I'm sorry.
Have you seen? Have you guys run into hospital-acquired infections? With your population at ChenMed?
Oh, I'm sorry. I thought you were using a different hospital acquired. I didn't. Yeah. I heard something completely different. So
it's the healthcare acronyms.
Yes, I'm sorry about that. So yeah, we have had so many. I mean, we've had adverse events. Patients end up in increasing length of stay, ending up in the ICU. Absolutely. I mean, really, that's something that we strive to prevent. We actually are very involved with our patients when they're admitted. But it's something that, once they're in the hospital, your hands are also tied to a certain extent. I mean, the patient needs to be taken care of for whatever reason they're there. But if they're there for something preventable, I mean, like we said earlier, Robert, you said prevention is key. I think you started off with that. Prevention is key to this entire discussion. I mean, really, that's it. Prevention. So we always look at solutions. We say medication reviews. Are we doing the MedRecs? Like we talked about being multidisciplinary, with our case managers, our pharmacists. Our pharmacists are extremely involved, making sure patients have medication and disease state education. Again, pharmacists, a lot of industry pharmacists do this too. They are very involved because they have new products coming out. So they actually talk about certain classes of medications. They talk about disease state education, which is very, very key. It's actually a very new, ongoing, but even growing niche for pharmacy, where how I look at it is like you're really using a pharmacist to their full potential, and then increasing follow-up frequency and communication. So yeah, absolutely. Sorry, I didn't understand the acronym you used at first, but yes, 100%. Hospital-acquired infections, we have seen them, and just like everyone else, including the patient, we are not a fan. I mean, but if you had something to prevent that, one, of course, keep them away from the unnecessary testing, the unnecessary hospitalizations, the best that you can. But kind of what Jerry's bringing to the table, you're bringing a technology. I mean, I look and think about tuberculosis patients. If somebody is in a negative pressure room in a hospital, It is always there's no good way to track. There's no sign-in sheet. You're not supposed to touch anything. You're supposed to wear the N95. If the N95 doesn't fit, you have to wear the big hood. And if somebody has facial hair like myself, or Faisel, the mask is not fitting. But with what Jerry's talking about, even for routine things like, hospitals have always been ready to deal with somebody who may have tuberculosis. It would be a great way to track. Because if you had somebody who was exposed or wasn't wearing the right PPE, you really could nip this in the bud. And this is a real great community service.
You bring up another point that I've been thinking about a lot recently from what I've been reading in the media about tying the prevention of COVID to just reducing mortality. And I'm not even thinking about, when I think about prevention of COVID, we shouldn't be talking about mortality with the prevention of COVID. We talked a couple of weeks ago, Robert, about the life expectancy gap across the country in different communities and neighborhoods. In New York now, between Manhattan and Spanish Harlem, it's a 10-year gap with life expectancy. In Chicago, 16 years. In NOLA, 25 years. Literally, there's zip codes in Chicago where the life expectancy is in the 50s in the United States of America in 2020. So now that makes me think about the millions of people who survive with COVID, and you've got COVID acting more and more like a vasculopathy. It's just affecting all different organ systems. Right? The way it acts, it just acts like this crazy vasculopathy. And then I wonder about for these millions of people who survive, who now have this diagnosis as a past medical, part of their past medical history, what will happen to their quality of life? If quality of life starts to decrease for these millions of people who survive COVID, there's a lot worse things than dying too, people. We have to remember that. What if it starts impacting people's ability to hold a job? If their incomes start going down, if now they start entering into the world of all the social determinants, what will happen to the life expectancy for people? Because we already know, if we got rid of all of heart disease in America, the numbers are just crazy. Almost half of Americans have cardiovascular disease driven by hypertension. We have now over 100 million Americans who have prediabetes or diabetes. I'm wondering what's going to happen. We have almost 10 million survivors in America from COVID. What are the long-term impacts, and how many of these people will start getting negatively impacted if the social determinants are going to start falling against them? And then what will happen to their life expectancy? I'm so worried when I'm reading these things about 99% survival, 95% survival. Whoa. We need to be more concerned about what are the long-term impacts of these people who are surviving with this.
And we need to ensure that we bring the focus back to primary care and ensure that those people have access to primary care providers to identify and to treat those potential long-term impacts. And then also, if they do start to have those impacts that cause them to fall into the social determinants of health, start to increase their social needs and potentially impacts their lifestyle behaviors, then you need that primary care relationship to ensure that those patients don't develop other comorbidities that cause them to go to the hospital, because this has potential impacts for general societal quality of life, our life expectancy and across different zip codes and as a whole across the country. And then also, what's most important in the case of COVID is people's ability to live happy lives. Not to mention the fact that people who might develop new chronic illnesses and new comorbidities can also cost a whole bunch of money going to the hospital. So I think we're definitely in a position where it's going to be important from a high level, and then for everybody across the country to refocus in on ensuring people have adequate access to primary care, and to ensuring those primary care clinics are able to operate at a really high efficacy.
Yeah, Robert Faisel, I just wanted to call out, Lynn Mason has made a couple of comments here, and Lynn is a ChenMed alum who is on to doing other things at this point, but really enjoyed working with her when she was here. And she's saying that many of these same issues in senior care and assisted living occur in the behavioral residential setting. these same tools and processes are very helpful in this space. And I think it's not only the technology tools, but what you're talking about, the social determinants that are going to happen here in the pre-existing conditions, they will even be magnified in that space. So I think Lynn is, I'll turn that over to the panel to chew on and discuss.
Yeah, it's a great point. I mean, we're seeing all the rise of depression and anxiety over these last. I mean, and we know that with depression, when someone becomes depressed, suddenly priorities shift, and especially with regards to the priority of taking care of yourself and your relationship with others as well. So I'm thinking, when we're living in this world right now, where you have 80% of the people having that get COVID have little to no symptoms at all, 15% have moderate symptoms, and about 5% end up having severe symptoms. When you have this rise of people who weren't previously diagnosed with depression or anxiety, now you're starting to have all these people. Then you have people who were previously diagnosed now being, with all the complications of all the isolation that has happened. Not everyone has the ability to be able to connect even in this virtual manner. I'm concerned about how seriously people take some of these basic preventive measures that do so much. We know already, we've said it, about the importance of wearing masks, the importance of keeping distance, the importance of washing our hands frequently, or at least before you eat. But yeah, in the behavioral health residential setting, my goodness, I worry about people with COVID fatigue alone.
Yeah. And Jerry, I'm curious, what have you seen in some of your data about depression rates during COVID among sort of the older adult population that use your platform?
Yeah. It's an excellent point. So our tool is incredibly useful because, one, we can quickly identify who was in direct contact with an infected person, right? And make sure that cohort can be isolated and quarantined. On the flip side, we also can make sure that all of those other residents can have some type of semblance of a normal life again. Because at the beginning of the pandemic, they were locked in their rooms, food was brought to them because we're trying to keep them safe.
Yeah.
But the prolonged duration of not having social community activities, no exercise, and we've had the percentage of time they're spending by themselves is it's horrifying, actually. I mean, the social isolation and depression rates are staggering. The general health of many of our customers, the residents in these senior living communities, it's the secondary effects, right? So these seniors are going downhill fast, and they may not have suffered from SARS-CoV-2 and actually the COVID disease, but they have had the secondary effects impact them. They don't have the visitation with their family and friends, and it has caused a rapid. So we're actually working on an NIH proposal for this to actually use our system to look at those changes in behavioral effects, right? And because we have the data on this and how we can use this tool as, the other side of the intervention loop, because now you can see, this can help impact, how they're responding and their actual behaviors, both BC before the coronavirus and AD after. So.
Yeah, gotcha. And I think all of these pieces, the COVID, the rising rates of mental illness like anxiety and depression due to COVID, due to isolation, and then the potential impacts it has for the exacerbation or new formation of chronic illness going forward is something that we do need to start talking about. So I've seen these graphs sitting around where the initial concern is like the wave of COVID that can cause death, and then the next wave is sort of chronic care that has been postponed that has led to out of control chronic illness, which is the next wave of concern, and then you have sort of this longer term wave, which is the impact of mental illness on overall healthcare outcomes and overall healthcare costs. And so those areas, all of these things lead to, out of control illness that leads to hospitalization and the use of the emergency department. And therefore it can lead to potential medical error if you have this happening in high volume. So I think that all of this is very much interrelated. And given that COVID has come onto the scene this year, that chart where we showed the leading cause of death in the United States, I know COVID has made its way up there as well. And then anytime you have more hospitalizations, more emergency department visits, more interactions with the healthcare system, you run into more potential for medical error. So all of these things definitely are interrelated, and it all comes down to the major causes of death in the United States. And it comes down to trying to prevent these all from occurring, whether it's preventing and encouraging the effective maintenance of existing chronic conditions, or working to prevent COVID, or falls in the case of CarePredict.
Mm-hmm.
Right, Robert. I mean, COVID has caused in itself its own Swiss cheese model.
Mm-hmm.
I mean, there's so many things that, we're taking care of COVID, we're taking care of what we can, but so many things have gotten missed, so many people haven't seen their primary care doctor. So many people haven't had the follow-ups that they needed, the communication that they needed. There's so many things that are interrelated. So yeah, I mean, we have to, of course, take care of and keep people safe, but we can't lose sight of the bigger picture either, that we still need to take care of everything.
Yeah, and I think that's an excellent point. And I want to make one final point, and then each of us, why don't we make our sort of closing statements about the topic? But I think there's a comment from Hector down here. I think is particularly important, is that there are people that care about this. We're talking about this. There's people that know that these problems exist. We've been talking about a lot of these issues with healthcare for a long time, and COVID has exposed those issues. But there are people that care. We get a little doom and gloom on the show a lot of times, but at the end of the day, people are working very hard and dedicating their lives and innovating their way to try and improve a lot of these things that we see in healthcare each and every day to try and make things better for our future. So I know we get a little bit disappointing sometimes, but we're working on it. And the folks at ChenMed and folks at CarePredict, like Jerry, are working very hard to try and actually make a better healthcare future. So with that, why don't we make our sort of final comments? That's mine. So Faisel, why don't you kind of close us out at the end? So why don't we start with Dr. Gheewala, and then we'll go to Jerry, and then we'll be good to go.
So thank you. It's a pleasure to be with you guys as always, Robert, Jerry, Faisel. I would say prevention is key. We need to be there for our patients. We need to be their eyes, their ears, their everything. We need to do everything we can to keep them away from harm. And like we said, when it comes to medical error, prevention. And I'd also like to take a moment to thank anybody who works in healthcare, no matter what you do. You don't have to be a physician. Whatever you're doing for somebody else, thank you so much, especially in a year like this. The amount of support healthcare has provided people, the reassurance. Thank you so much, because a lot of errors have been prevented. We have to keep that in mind. There's a lot of errors right now as we have been speaking. Errors are always being prevented. Of course, there's always errors that are going to always show up, but that means that there's always somebody around that can fight those errors. So thank you to everyone who works in healthcare. We really appreciate it, because I know the patients do.
Faisel, thank you so much, and Robert for being on the show. I really had enjoyed the opportunity. I think the key that I want to drive home for us is, activities and behaviors are the next vital sign. There's been a tremendous focus on heart rate and blood pressure and weight and things that I think are more closer to a diagnosis and much more reactive model. And you need to get upstream. In those changes in activities and behaviors, we know are strong correlates for whether it's depression or a UTI, whether visits to the restroom or falls, changes in gait, number of times they're getting up at night and restful sleep. So in order to predict and prevent a hospitalization, you need to get that information. And I think that the tools like our wearable and beacon system that can unobtrusively collect that information is going to be really critical. And I think going forward, other tools that, through sensor fusion can pull in data on the activity and behavior of seniors can help us get upstream and help, provide a better life for them.
Thank you, Jerry. We really appreciate you coming out today and just taking your time. I appreciate Dr. Nehal Gheewala for number one, being my father's doctor. And number two,
a pleasure always.
For taking time out of the clinic. I know you're at the center right now to take time over your lunch to join us again. I really appreciate that. I know how busy you are. We're in the full risk model. We're not a hybrid value-based care model. We're the full risk model. So he's got a lot on his plate, especially being a medical director, managing anywhere between $20 to $25 million of risk at any given time. We appreciate you for taking that time, Dr. Gheewala.
It's my pleasure.
And Dr. Dan, thank you so much, Dr. Dan, to manage the chat, to bring in these great comments. We had some great comments today. For the people who participate in the chat, that's what we want. We want to have more of this type of dialogue to try to make it as interactive, take a break out of our crazy days, our crazy weeks, try to end it with a message of hope that there is a better way to deliver healthcare. So to all of you, thank you for joining us. For more information about today's topic and where you can also explore opportunities that we have at ChenMed, please visit chenmed.com. We believe healthcare is a right, not a privilege.